Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the Department of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome Dr. Stephen Hearne back to the program. You are a cardiologist with Delmarva Heart, and you're also Director of Cardiovascular Services at Peninsula Regional Medical Center.
That's correct.
And you've been on the program before. You've taken us into the OR and different topics. Today we are going to focus on atrial fibrillation. Quite common, isn't it?
Very common.
How common is it?
So atrial fibrillation is one of those cardiac diseases that's very age-related. So people in their 30s and 40s, the prevalence is probably under 1%. Once you get up into your 70s and into your 80s, it's in the 10 to 15% range. So it's a very common problem in a cardiology practice. We see it every day, several patients every day that come in with it. So it's probably the most common arrhythmia out there. And the biggest risk factor for it is advancing age. Other factors that cause it, overactive thyroid, which is rare, but it does cause it sometimes, long-standing high blood pressure, obstructive sleep apnea, obesity are all risk factors for it. Again, high blood pressure, heart attacks can cause it. Sometimes you get it after open heart surgery. There's multiple causes.
What exactly is the problem with atrial fibrillation, or the cause?
So the problem with atrial fibrillation is, the top chamber of the heart are called the atria, and that's the chamber that holds the normal pacemaker of the heart called the sinus node, which usually drives everybody's heart regularly. And when you're at rest, it's slow, and when you exercise, it goes fast. Atrial fibrillation is when kind of multiple pacemakers, like thousands of them in the atria, sort of take off, and the atria quivers and doesn't really contract on its own. So by doing that, you get multiple sort of chaotic electrical impulses, some of which get through to the bottom of the heart, the ventricle, and some which don't. And it's very haphazard as to what gets through to the bottom. Because it's haphazard, the heart beats irregular. So you get an irregular heartbeat, and a lot of times, and you don't have the same controls in terms of your heart rate. So a lot of times people feel the heart going very fast. The problem with atrial fibrillation is because the top chamber, the atria, don't contract and sync with the bottom, you get what's called stasis of blood. So they don't contract, so you get areas where the blood really doesn't move, which predispose you to forming clots, which predispose you to having a stroke. So people in atrial fibrillation in general are about 5 times the risk of people that are in normal rhythm for having a stroke. And the stroke risk increases the older you get. So the big problem with atrial fibrillation is stroke risk. Unfortunate thing is, once you have atrial fibrillation, there's no way to cure it. There's multiple things to treat it, but there's nothing you can do that will guarantee that it'll never come back. I mean, there's medications you can treat it with, there's catheter ablations, there's surgical ablations, open heart surgery, there's catheter ablations, and none of which will cure it 100%. There's a lot of it that can make it go away, and go away for a while, sometimes for years, but once you've had atrial fibrillation, you're more likely to get it again, and there's no medicine, drug, or procedure I can give you, do to you, to say 100% you'll never get it again.
You hear about people saying they go in and out of AFib.
They do, and a lot of people, not everybody's symptomatic. I mean, it's amazing how some people will come in not having any symptoms or not know they're in atrial fibrillation, and a lot of people know the moment they flip into it from normal rhythm, they get acutely short of breath, or their heart races or skips, or they get chest pain or tightness, they get lightheaded or dizzy. Those are some of the common symptoms. Not everyone gets those, and it doesn't really matter whether you get them or not get them. If you have it, your stroke risk is kind of the same. So that's the big worry. With that whole disease, there's different things. There's rate control. There's trying to control rhythm, where we put people to sleep and actually shock their heart back into normal rhythm. And I guess, as I said, the catheter stuff. The most important thing about it is to be on some type of blood thinner to prevent a stroke. And there's like 5 out there nowadays.
Right, we'll get to that. We're going to talk about the treatments and such. But I know one thing we can mention, when there's problems with the atrial pacemaker, it's not nearly as life-threatening as when you have a problem in the lower part of the heart. There's ventricles.
There's ventricular fibrillation, which that's like dying. I mean, your ventricle fibrillates, that's where they shock you back to life, like you see on television, the emergency room guys. So that's a whole different ball game. We're talking about the atria is the top chamber. The ventricular fibrillation is kind of the life-ending arrhythmia after big heart attacks or other things that cause
So the main
that.
thing you worry about is the stroke risk, and we'll get
Correct.
to that because there's medications people typically go on to
That's correct.
prevent that from happening. So you're saying the symptoms again, just state them again?
So symptoms in general, if you have them, and again, not everyone has them, some people have none, but if you have them, a lot of times it's palpitations, heart racing, skipping, extra beats, shortness of breath. A lot of times more fatigue, they'll feel tired or unable to do as much as they could do before when their heart was in rhythm. Sometimes they get chest pain or tightness. That's rarer, but that happens as well. Lightheaded or dizziness, because sometimes when you're sitting around with atrial fibrillation, just like you and I are right now, your heart can be going 130, 140 beats a minute rather than the usual 50, 60, or 70 that it is when you're in normal rhythm. So you can get lightheaded or dizzy, especially when you try to do things. So a lot of those symptoms are very nonspecific. There's a lot of things that can cause those, but those are the things you think about when you have them. And diagnosing it is pretty easy.
And how do we diagnose it?
So getting to that, so the easiest thing is an EKG or a monitor. I mean, you're a physician, your family physician, or your whoever you see, or even a nurse or a lay person, a paramedic on the street. An easiest way to do it, I say a poor man's way, is just check your pulse. I mean, the normal pulse you can check on your radial artery, which is down below your thumb, your carotid artery, which is here in your neck. And in a person normally in a rhythm, it should march out just like a drum. You should be able to march it one beat after another. With atrial fibrillation, it's all over the place. It's kind of like a gun going off intermittently. So there's intermittent beating, and there's no way you can march it out because a beat will come, then you'll have a pause, and you may have 4 or 5 fast beats in a row, then a shorter pause. So that's kind of the easy way to at least suggest that you're in it. But the way to 100% confirm it is to get an electrocardiogram or at least a rhythm strip.
It's very easy to spot on the electrocardiogram.
Yes.
So.
Yeah.
And is exercising tend to bring it on, or just no reason?
No, exercise for people that usually are not extreme athletes. There is some data out there that extreme athletes, people that do super marathons and run these 100-mile things, they actually are at higher risk, and marathon runners are a little higher risk for it due to the stretch and strain on the heart. But in general, moderate levels of exercise are actually protective against atrial fibrillation.
Is it higher in men versus women?
No, it seems to be, I think, about the same.
So diagnosis would be with the electrocardiogram, and of
Yes.
course looking at their symptoms that they
Correct.
may be complaining of. And they can come and go, correct? And then you're
Yes.
saying some people don't have any
you can go in
symptoms.
rhythm, and sometimes people can go in and out of rhythm. You can go in atrial fibrillation for 3 or 4 hours, then go back into normal rhythm, stay in normal rhythm for 3 or 4 days, and then for whatever reason go back out of rhythm. And there's a lot of times no rhyme or reason. Sometimes, there's some folks that, can be triggered by caffeine, alcohol. Alcohol is a big one that can cause it, what they call the holiday heart syndrome, which you hear after New Year's Eve and stuff like that. A lot of people drink a lot the night before, and they can put their heart out of rhythm with alcohol just from doing that. So that's another sort of reversible cause.
There are more heart attacks around the holidays, aren't there?
There are.
Yeah. Okay, so now that we've talked about the symptoms and diagnosis and risk factors and so on, let's talk about treatment. And I guess let's first start with, there are medications, correct?
There are. So there's several what they call
treat the
lines.
rhythm, and then
there's
the ones
several
you
lines
take.
of medication to treat the rhythm. I mean, calcium blockers, such as verapamil, or diltiazem, or cardizem, people may have heard of, or Cardia is one of the generic names, or metoprolol, beta blockers, low pressor, metoprolol, toprol. Those are beta blocker type things that we use. And those are sort of first line agents. Not a lot of side effects, not a lot of downside. Most people tolerate them. Not a lot of monitoring needs to be done. So a lot of times you'll start with those, and they'll usually slow the heart rate and sometimes can convert them into rhythm. And then there's what they call antiarrhythmics, which, a little bit stronger medications, typically a little more side effects. There's several different classes of those out there to treat it that actually are antiarrhythmics that help try to keep the heart in rhythm.
And they're a little more involved.
A little more involved. I mean, typically monitored by a cardiologist routinely. Some of the other ones, the more potent ones, can have a thyroid, liver effect, sometimes lung effects. Some of the more potent ones, one called amiodarone or pacerone, is probably the most potent one out there for treating it, but also has the most side effects. And so things like liver, you have to follow, thyroids and other things, you have to follow that. And some of the less stronger antiarrhythmics, you don't have to follow things so much, but they're also for more specified groups of people.
Well, there's calcium channel blockers and beta blockers are used for blood pressure management too. So a lot of people are on
kill
those.
2 birds with 1 stone. That's exactly right. That's
So
exactly
then
right.
you try those type medicines.
So you try
first.
those, and and if they don't work, a lot of times one of the first things we'll do is we'll thin somebody's blood, and we can put them in the hospital for what they call an outpatient cardioversion, where we put them briefly to sleep. and we put the paddles on them and shock their heart back in rhythm. And that's successful 75, 80, 85% of the time to restore normal rhythm. Keep them on the meds and with hope that it's going to stay in rhythm for an extended period of time. Again, no guarantees. We tell patients, we can do this today, it might work today, and you could go right back into atrial fibrillation tomorrow. It's kind of like one of the last frontiers of cardiology. We're pretty good with stenting and fixing valves and doing bypass and all those sorts of things. This we're not quite as good at curing. In fact, we can't cure it. We can treat it, but we can't cure it. And sort of the last not really the last resort, but what used to be the last resort, although technologies actually evolved, so that's actually one of the first line things now, or close to first line to what they call cardiac ablation, where you actually can go up through a vein, and they can find in the area in the atria where the AFib impulses start, which is typically around the pulmonary veins, and they can do what they call ablation around your pulmonary veins. And that works the first time around 70 to 80% of the time. And some people have
actually killing the tissue.
Yeah.
So it's not
so it can't propagate its impulse, correct. And some people have to come back a second time, and you can get, what they call cures of up to 90%. With even a second, 90-95% with a second, and sometimes even a third go around if they're real symptomatic. The issue is, it's invasive, it's up in the heart, has very very small of perforation, stroke, all those sorts of things. They're very low, under 1%, but they're there. But that's a good treatment, and that's gotten better. Back when it first started, the catheters were big, the procedure took a long time, and it was kind of a last resort. That procedure's actually moved more and more towards the forefront, so that I think the Heart Rhythm Society nowadays, you can sort of try some medicine and maybe pretty quickly go right to an ablation.
Go right to ablation? Yeah, that used to be the last resort.
It's gotten quicker, more efficient, the catheters have gotten better, they're smaller, they work better. So that procedure's really catching on, and that's kind of the electrophysiologists, which are the kind of electricians in cardiology, that's kind of their bread and butter anymore. That, along with devices, that's one of the big things they do, because atrial fibrillation, as the patient population ages, is never going away.
You're just going to see more and more of it.
Probably age is the biggest risk factor.
So no matter where someone is on the treatment spectrum, they are going to be prescribed an anticoagulant type drug.
So in general, that's true. So we use a couple scoring systems, and the one scoring system that as docs we use is called the CHA2DS2-VASc score, which looks at risk factors that we know establish your risk for stroke. So C is for congestive heart failure, gives you a point. H is for hypertension, age. So there's two age categories in that. 65 to 75 gives you 1 point. 75 and over gives you 2 points. Diabetes gives you 1 point. Previous stroke or TIA gives you 2 points.
TIA meaning?
Mini stroke, it kind of goes away. Vascular disease, such as coronary disease, you've had a stent somewhere, that gives you 1 point. So, and then sex, being a woman puts you a little higher risk, that gives you 1 point over being a man for stroke. So what you do is you add all those up. Once you see a patient, that's how we figure out where they need a blood thinner. So somebody who's 30 with none of those risk factors, typically no. Most of the patients I see in practice, they typically need something, because for sure with a CHA2DS2-VASc 2 or above, if you have 2 points, you've had a prior stroke, you're over 75, got AFib, you need it. And a lot of people would even argue, some of the purists would even argue with a CHA2DS2-VASc 1, mean if you're a woman with AFib, you're a little higher stroke than a guy, no matter what age ratio. But in general, 2 is a definite, 1 is on the borderline for some people. So based on that is when you decide to put them on a blood thinner, anticoagulant, which for 50 years was Coumadin or warfarin, what my patients like to affectionately call rat poisoning, which is what they use to kill rats in a day. So that's a tough drug to take. A lot of different medications interfere with it, send the levels up. A lot of different foods do. You got to watch your green vegetables. You have to come to my office and get monitored at least monthly when you first start. A lot of times it's weekly. It's a finger stick. They draw your blood, with a little finger prick. They put it in a machine. They tell you what you got to do, and the dose is very variable, because Coumadin or warfarin is one of those things that affects, at least 4 clotting factors, which are different in different people, the different amounts. The newer ones out there, which you really just came around 2010, the first one was approved, Pradaxa, and there have been since 3 more. They only affect one factor in the clotting cascade, which is pretty constant person to person. So the newer ones don't require any monitoring, except for getting a blood count and a kidney test, because they're all renally cleared a couple times a year. And they have a really better bleeding profile and a better stroke prevention profile. So they're better. They're clearly better. There's four of them out there. Yeah. The downside is none of them are generic. Coumadin is generic as warfarin, so it's cheap. The new ones are all commercial.
That would be Pradaxa,
Pradaxa, Eliquis. Pradaxa and Eliquis are both twice a day. There's one called Xarelto, which is once a day, and another one called Zavesa, which was the last one on the market, came out about 3 years ago, and that's also once a day. But they don't require any sort of, again, monitoring. And we don't know which one of those is better. There's no head-to-head between those. They all made the market because they're better than warfarin or Coumadin and easier to take. Less intracranial bleed rates. Warfarin's a big one for causing head bleeds. We see them all the time because INR gets out of control. These are a lot safer for bleeding. Overall bleeding profile's better, and they prevent strokes better. So anyone we can get on one of the novel oral anticoagulants or newer ones, we put them on. I don't start people on warfarin myself anymore unless it's an absolute last resort because it's a hassle for the patients. It's not as good for them, and it's a hassle for the doctors taking care of them.
And if the other drugs are more effective, the downside is the price. But.
Correct. Although most of them are pretty good tier 2 in most systems now. Most people can get them, some as little as $5 a month, some with copay cards down to $0 a month for commercial. And then there's other ways you can get the patients the medicines. But most of them would prefer even paying the extra because by the time you do the math, the gas and the time to come to my office to get it checked, it's almost a wash, and it's just easier for the patients.
And all the lab follow-up and such. So, yeah.
Right.
Well, that's good news then that we have, some new drugs there in that regard. So, so let's emphasize again before we finish about prevention. Is there anything people can do to prevent atrial fibrillation?
So prevention, it is hereditary in some people. I mean, I have people in their 20s and 30s. There's not much you can do with that. They get it. The other things, prevention are watch your weight. Exercise is somewhat preventative. Keeping your blood pressure under control is preventative. Thyroid is something that, an overactive thyroid can put you into atrial fibrillation. That's an easy blood test.
We have medication for that.
Yeah, which everybody checks. Somebody has new atrial fibrillation. It's routine for the physician to check their thyroid. Every now and then, a couple of times a year, it'll come back overactive. It's a reversible cause. You fix the thyroid, the atrial fibrillation goes away for a long, long time.
Well, the thyroid puts out the hormone for metabolism, just revs your heart up.
And overactive just revs it up too much. So, healthy lifestyle, not binge drinking, minimal amounts of alcohol, a drink or so a day. Or, alcohol can put you over the edge. Just healthy life. That's other than the healthy sort of routine things. There's not one sort of thing that say you do this every day, you'll never get atrial fibrillation. But the general healthy cardiac lifestyle things are good.
Yeah, and at least
stay away from the energy drinks too. All these kids with the energy, the monster drinks, and the other things, because there's a lot of case reports out there of kids putting themselves into it by taking 3 or 4 of these.
I've been skeptical.
They're bad. They're bad for you.
All the evidence is starting to
absolutely
mount.
A lot of cardiac arrhythmias. I mean, some kids have taken too many and actually died from
there was that
arrhythmias.
one case between coffee and the energy drinks and
so those are things to stay away from.
Yeah, well, good advice, good advice. And what we'll do is we'll post some websites you recommend for people to get more information about atrial fibrillation. And again, thank you for being on the program.
You're quite welcome.
And coming in and talking to us about this common topic. You hear a lot
about
it.
Very common. Yep, very common. Thanks for having me.
And thank you for joining us for this edition of Focus on Health here on PAC 14.